So here, you can advance your slide here.
Is that for me?
That's for you.
That's awesome. Thank you.
Great.
What is the
The point, lose point is the red.
red? Okay.
Yeah.
All right.
Okay. Alright folks, we're going to get started. So today's speaker is Behnam Saberi. We've been trying to get Behnam in, alright? Because Behnam is a newish attending here at MELD. Coming to us from Johns Hopkins, but it's been a while now. Well established here. So Behnam's going to speak to us about using DAAs and its association with HCC. So thanks, Behnam.
Okay. Thanks for coming. So of course we're gonna start with some background about hepatitis C, and then I'm gonna dive into the topic. So just a reminder, this is an important timeline for us to understand. So as you know, around 1970s, that's when the term non-A, non-B hepatitis was there. They knew about this disease, but they didn't really know what was going on with the patients. And then later on, interferon was discovered, and then 1989, hepatitis C virus was discovered. And then, of course, they started using interferon with ribavirin for hepatitis C around 1999, and then the pegylated form of interferon came in 2001. And as you know, the interleukin-28 was a big discovery too around that time. Now, of course, this direct-acting antiviral started coming FDA approved. First one, if you remember, was some of these first-generation protease inhibitors, such as tenofovir, boceprevir, which came published in a couple of papers in New England, but was approved for genotype 1. And subsequently, the second-generation protease inhibitors came in 2013. If you remember, cimeprevir was the main medication. And then followed by sofosbuvir in 2014. If you look at the sustained virological responses, and for those of you who don't know much about the hepatitis C area, we can just say cure rates. If you look at the cure rates on patients with hepatitis C, the early treatments, the response rates were really extremely low. And then even when they added ribavirin, it was pretty much below 30-40%. Even with the PEG interferon ribavirin, I would say the responses were not great. It was really a patient-dependent thing. Some of the populations had higher failure rates. So I would say a lot of the patients even below 40% response rates. And then when the first generation came, the response rate increased to about 60% or so. That's when we had the tenofovir, boceprevir, and then subsequently we had the future therapies that came. As you know, the interferon therapies were associated with significant side effects. That was one of the major problems we had with these medications. And of course, with the current treatments with newer generation DAAs, it's really revolutionized the field of hepatitis C with response rate of above 90% in most patients. These drugs overall, mainly work in NS3, 4, NS5A, and NS5B. These are non-structural proteins that are involved in the hepatitis C translation, polyprotein processing, and translation, and basically they prevent RNA replication, and that's how they basically treat the hepatitis C virus. Again, non-structural proteins, mainly the drugs that are used currently in the clinics. There are a combination of these drugs, usually a combination of 2 drugs, sometimes 3 medications or substance. For example, one of the newer generation drugs that was discovered was Mavorite, that is a combination of NS3 and NS5A. And of course, the drugs that come from Gilead are more using the NS5A and NS5B. For example, Harvoni is a combination of this medication with sofosbuvir and then Epclusa which was a newer medication, is a combination of this drug with this drug. Usually patients take these medications for about 8 to 24 weeks, depending on the situation. When they came originally, they were some of these harder to treat populations, but a lot of these populations even are fading away because the drugs are so efficient. For example, the treatment experience, HIV co-infection or post-transplant, a lot of these conditions these days are actually pretty easy to treat. Just to remind you, for example, sofosbuvir and ribavirin was one of the earlier regimens that was being used before we have the most recent medications, and the response rate in genotype 2 was pretty good, but just want to remind you in genotype 3, for example, especially if they have cirrhosis, the response rate with some of the older medication with SOF and ribavirin is pretty low. So this regimen, for example, currently considered one of the inadequate regimens. It's not really being used anymore, but I think it's important to know when we go through some of these studies when I present. I think it's important to know these. With the Gilead medications, Harvoni and Epclusa in patients with child-age cirrhosis with genotype 1, they have excellent response rates. I mean, they're in the high 90s. Even with cirrhotics, with the child B's, still the response is pretty good. We know that the Epclusa is just finished. We finished the trial here, so we will see what the results will be. But I just wanted to give you some idea about how these medications work even in patients with cirrhosis, even with decompensated cirrhotics. Genotype 3 is still a little bit challenging. I think this is one of the kind of last groups that are left to be treated. And if you look at the cirrhotics, this is Epclusa medication. The response rate can, decrease to around 50% in some patients. So genotype 3 decompensated cirrhotics are still challenging in some patients. So again, this list has been shrinking as I showed. We're still dealing with some of the tough patients, including DAA failures. Vosevi was a new medication that came as a combination of 3 drugs that we can use even with DAA. One of the problems with that is we can't use them in decompensated cirrhotics because it has protease inhibitor in it. As I mentioned, decompensated cirrhosis genotype 3 is a bit challenging. But the question is, what about hepatocellular carcinoma? And as you know, in the US, hepatitis C is the main cause of hepatocellular carcinoma. And it's mainly forms in patients with cirrhosis. More than 90% of these patients are cirrhotics. One of the things is the hepatocellular carcinoma patients were excluded in most of the original trials, so we don't know basically much about these patients with the hepatitis C. And that's what the purpose of my talk is. I wanted to go through this topic and see what type of data is out there that talks about this specifically. So this is a case that I saw in the clinic. I just wanted to give you an example. This patient came to us, 15 centimeter mass with alpha-fetoprotein on the 180,000 range. Of course, is arterial enhancing with some necrosis in the center. Without any METs, patient eventually got transarterial chemoembolization, had genotype 1, treatment naive, and we put the patient on Epclusa for 12 weeks. The original RNA was 1.3 million and eventually dropped at 4 weeks to 885. And again, I want to show you at 8 weeks is still a detectable virus, and that's what I wanted to talk about. I just want to give you a case so we can start discussing the papers. Unfortunately, this patient got sick, admitted to the hospital, eventually could not tolerate the medication and went on hospice care. So one of the original papers that came in 2017 talked about this, and it's a retrospective study that looked at 21 patients who were undergoing liver transplantation. And these were patients with hepatocellular carcinoma and hepatitis C. One of the things, if you notice, is the genotype is pretty heterogeneous among the patients. So most of them are genotype 1. Most of them are child class A, but some are more decompensated based on the numbers. And some of them are treatment experienced with various viral loads. They reported using, I'm sorry?
SIMSOF in the child C, Submit yourself hospital in the child C.
Yeah. Yeah, well, some of them, the medications were not available at the time. So, you know what I mean? At the time, that's what they had, and that's why they used that. And again, the treatment regimens are pretty heterogeneous. Again, that's important to notice. As you said, SIM, SOF, ribavirin, these are considered inadequate regimens right now. So when we're looking at these type of papers, it's extremely important to pay attention to these details. And again, some of them use ribavirin, and then duration of therapy is also important, which is 12 to 24 weeks for most patients. If you look, they did not have any virus at 8 weeks or end of treatment, but then eventually all of these patients relapsed after they received the first course of DAA. So based on this information, they reported a relapse rate of about 33%, which will be a SVR rate of 67%. And these are all pre-liver transplant patients. And subsequently, all of these patients underwent liver transplant between 2 to 12 months after, and subsequently were treated and achieved SVR after liver transplant.
So just to make sure I understand how they're defining relapse. So these are people who completed their planned course of therapy and were HCV viral load negative at the end of treatment. Is that how they define relapsers? And then they became...
End of treatment was negative.
But did they complete the course of treatment that was intended?
They did.
Thanks.
They all did.
And one other quick question, were they actively getting HCC treatment, do you know, or were they done with their HCC
Yes,
treatment?
these were mainly patients that were within Milan criteria or being downstage to Milan criteria with TACE or local regional therapies before they get to transplant. Anyways, this just shows the explant pathology. As this is what I was going to say. They were downstage with TACE. This is the results of the TACE and the differentiation. I will talk briefly about two other papers, and then I'll start summarizing what I'm showing here. This was a second study that looked at kind of similar data. They had about 400 patients, HCC and non-HCC, 137 patients that were HCC. Overall, HCC group are older patients that were more male, and most of the patient population were white. And it's important to, again, differentiate between the MELD scores and child Pew scores. As you can see, the groups are not completely the same, and I would say they are more compensated patients in the HCC group compared to the other groups. So again, there are more decompensated patients on the non-HCC group, and as I mentioned earlier, this is one of the risk factors actually for failing treatment. Again, they're showing their lab and bilirubin pretty much the same between the two groups. It's important to know the treatment experience groups. It's about 50-60% of patients had prior treatments, and genotypes were pretty much the same between the two groups. But again, as you remember, I mentioned the genotype 3 patients could fail with higher rates, and that's why if you see there might be more genotype 3 between the two groups, and that's one of the problems with this, doing these type of study in a retrospective fashion, because you can't really control for all of these variables, and that might affect your results at the end. So they also, of course, give the summary of their tumor characteristics, but again, about 40 or 50% of them had active tumor at the time of the study, and most of these patients are patients who are in the BCLC-A group, about 63%. And again, you can see the number of lesions. Most of them are 0 to 1 lesions and more. Not a lot of Mets here. And they got a heterogeneous type of treatments, including liver transplant, Y90, and this Y90 is a local radiation, and then transarterial chemoembolization. What they reported in the study, again, is that patients who were in the HCC group had higher failure rates compared to the patients who were not in the HCC group. But again, the two groups were not completely the same. And again, the response rate that were reported in the study was 79%, which was lower in the HCC group compared to the non-HCC group. Just to summarize their univariate analysis, the factors that predicted treatment failure, again, were more decompensation, genotype, of course, genotype 3s, and type of HCV regimen that was used. And the most importantly, relevant to my talk, is HCC. Active HCC was one of the predictors of treatment failure with the hepatitis C medications. This goes through some of the treatment regimens that they use. A lot of them use SIMSOF, and this is Harvoni, and you can see that the failure rate is higher in the HCC compared to the non-HCC group. But again, as you can see, the treatments are very heterogeneous. It's not like, you know, one or two drugs that use multiple drugs, so it's a bit hard to really pinpoint which one was a higher failure rate. And you know, they concluded that about 50 to 60% of patients did not use adequate regimens. And then the multivariate analysis, just to summarize the study, the factors that predicted treatment failure were inadequate regimens, which again are SIMSOF, right, and sofosbuvir and ribavirin, and also the patients who had active tumors. As I said, the two groups were different, but they adjusted for some of the other risk factors, and they still showed that the HCC was one of the main predictors of treatment failure. The second study, it was done in a VA, and as you can see, they have large number of patients. And again, the HCC patients are usually older. Most of the VA patients are male. And again, one of the things that I wanted to show, very similar to the previous study, some of these numbers are totally different between the two groups. And these are some of the factors that could predict you know, Hep C failure. For example, treatment experience were more common in patients with HCC, so higher over here. And the other thing I wanted to show is the decompensated cirrhotics were more common in the HCC group. And again, genotype 3 was more common in the HCC group. And the labs were completely different between the two groups. And again, the reason is because the HCC group were more cirrhotic and more decompensated. So it's important to pay attention to that. What they showed in their SVR rates, again, in this study from VA, showed that the SVR rates are higher in patients with HCC. When they looked at the specific genotypes, they showed that the patients with genotype A 1 and specifically genotype 3 had significantly lower SVR rates. And you know, the treatment, this was correct across the board for treatment experience or cirrhotics. On the multivariate analysis, they adjusted for some of the other risk factors, and they showed that, again, HCC negatively predicted SVR rates in these patients. So just to summarize this section, there are multiple studies have shown, as I said, the HCC patients were excluded from the clinical trials. A lot of these studies are done in a retrospective fashion, and you can see this are summarized in this table. The number of the patients are mentioned, about 40-50% are treatment experienced. Most of these studies use patients that are cirrhotics, and This table here shows you how many percent of the patients are decompensated or compensated, which is pretty variable among the studies. And finally, most of these studies show that the SVR rates are a little bit lower in the patients with HCC, maybe about 20%. This was a more recent study that was presented in ASLD last year. It's a postdoc analysis that looked at the same question, and they showed that the SVR rate was 89% in non-HCC, and in HCC was about 10-20% lower. One of the, again, problems is the terms of genotype, type, and duration of DAA is pretty different between the between the groups and all of the studies. So if this is correct and the SVR rates are less in HCC patients, what's the proposed mechanism of this? So there are various different mechanisms, has been proposed in some of these papers. And one of the things that I wanted to show, again, the most common way of hepatocellular carcinoma blood supply is through the hepatic artery branches and not through the portal vein. And again, it makes sense that this becomes a place for the virus to grow and stay there, and maybe the drug is not really getting to that area, and that's one of the reasons maybe why we have less SVR rates in patients with HCC.
Is there any role for the immune system after you reduce the virus to actually maintain it at full levels?
I think that becomes more important when we talk about some of these papers talking about HCC recurrence after. I actually have that in another slide. But yes, I mean, one of the things about the immune system they're proposing is when you shut off the hepatitis C and the immune system related to hep C, there is a dysregulation in the breakpoint and immune checkpoint system, and yes, has been suggested, but not as specifically related to lower SVR rates. I didn't see anything related to that topic. The other reason why failure rates are suggested is so one of the papers suggests that maybe sofosbuvir is one of the drugs that actually patients have lower SVR rates, because sofosbuvir actually has to be converted to the active metabolite before it gets active. So it has to undergo phosphorylation inside the hepatocytes. And again, if this is not happening inside the tumor cells and the blood perfusion is different, that could be one of the proposed mechanisms that was suggested. So we don't know if it's really the sofosbuvir related drugs have higher failure rates, but that's some proposed mechanism.
So do you know what the first pass extraction is for oral DAAs? In other words, if the drug is efficiently extracted to hepatocytes through the portal vein when it's taken up, how much is going to be left to recirculate and get back to the tumor?
So there, with the sofosbuvir, I think is only like 10% or so. So I guess most of it is,
oh, I see, it's right
yeah. So most of it gets active right away. So there's not much getting to the tumor from the others.
I see.
Yes.
So there's only 10% left.
Right, and that's
Through the
right, and that's the whole concept about this idea. Like, that's a great question.
Not that it's probably not worth doing, but just Andy Talal had a paper where he did skinny needle aspirates to assess intrahepatic levels of drug in patients on DAA. One could conceivably do that in a tumor in a patient who's recently, either by skinny needle biopsy or if they undergo surgery.
Or I guess transjugular liver biopsy, but I don't.
Be directed.
Yeah, that's right. There are some other proposed mechanisms. Again, you see some of them. Maybe the resistant variants are different. One paper suggested that maybe some of these transporters are different for DAA uptake in hepatocellular carcinoma specifically. So we still don't know. These are all kind of proposed mechanisms. But if this is true, really, I think some of the clinical implications of this will be, should we do longer duration or add ribavirin to the regimen for these patients? And then, you know, if somebody fails DAA, should we do an imaging to make sure they don't have cancer? One paper suggested that the HCC patients actually could have very late relapses. So in HCC patients, they suggested to keep checking the, you know, HCV RNA a little bit longer if somebody has HCC, because that has been reported. And again, there is this whole topic of pre-post-transplant, which I try to talk a little bit about if we have time at the end.
People have HCC who are recurring failed treatment. Do we know if they are cirrhotic or non-cirrhotic patients?
So I showed all of that in the beginning, but just to summarize for you, most of the patients who were treated in the trials, yes, 90% of them are cirrhotics. But one of the problems with the studies are all retrospective. A lot of the patients were excluded from the clinical trials with HCC, so we don't know them in the trial setting. But one of the points is that the decompensated versus compensated percentages might be different when they report the cases in the study between HCC and non-HCC. But the majority are cirrhotics. Now, the other questions come about is, what about the size, number of the tumor? Does that matter? Does it affect the treatment, SVR rates? Does the Y90 resection, liver transplant, does that matter? And, you know, I try to address some of these questions. This was a proposal that we made to study these, this topic, and kind of was turned down by one of the drug companies. But we basically wanted to look at it from a trial standpoint, to look and see if the duration or the ribavirin will affect, you know, the response rates. And again, one of the problems was we needed a lot of patients, and it has to be done in a multi-center study, and that was not really good. So the other topic that I will touch base briefly, because it was reviewed recently by Mani and Dr. Dietrich, it's a whole concept about DAA causing recurrence. These terminologies are important. Recurrence refers to a patient that had previously cured HCC and now has recurrence of HCC. Occurrence is mainly a new HCC lesions, kind of like a de novo is another terminology that is used. And again, just for those of you who don't know, they are through the hepatic artery branches. They can access the tumor and use chemoembolization or radiation is called TACE and Y90 that are extensively being used in patients with HCC. So one of the original studies that was published was this study that basically suggests that DAA create a lot of recurrence post-HCC treatment. If you look at their patient population, most of them are cirrhotics, 90%, and most of the patients were child class A, and most of them were BCLC class A patients. Patients were majority genotype 1B, and all of these patients were treated with DAAs. Again, the regimens were pretty heterogeneous between the groups, and you can see 30% underwent resection, the RFA was 55%, and 10% underwent TACE. The way they reported their data is a bit too much, but I can tell you. So they're basically talking about 3 columns here. The first one is basically at the time of HCC treatment and last imaging showing that there was complete radiologic response. The second white box is the last complete radiologic response and DAA initiation. And then the black boxes are the patients who failed. Were about 16 patients, who had progression of HCC. We're talking about the patients who are in black. So what they showed is patients who received DAA, out of 50-something, 16 patients had HCC recurrence. That's what they showed in this study. And again, they showed their data, their resection some got resection, some got ablation. We don't have pathology here, and then they tell you what risk cancer they were. And then eventually, at the time of HCC recurrence, they tell you what kind of biology they had. One thing I mentioned is after that original paper, there has been multiple papers published in the topic. I mean, it's extremely difficult to go through all of those topics, but I think this would be a good example. This was a meta-analysis that was done. They reviewed all of the papers that was recently published on the topic, and they looked at basically HCC occurrence and recurrence. And some of the studies were positive, some of them were negative. And eventually what the meta-analysis concluded is they said that we do not see any association between DAA and risk of occurrence, or we do not see any association between DAA and risk of recurrence. And this was the original study that showed the positive result. And then you can see a lot of the studies basically did not show any association between these two. So again, it looks like there might not be association, but still I think hasn't been done in a clinical trial setting. So that's why we don't really know the answer to this question.
If you go back to the slide, I think it's important to point out that there is a significant heterogeneity in these analyses.
Absolutely.
I-score is 90%.
Right, absolutely.
I'm not saying that the answer to the question, but I'm saying methodologically,
yeah,
there's a lot of concerns about this.
I agree. And that's why one of the reasons I said we don't really know the answer to this question yet. I think that's important to notice. But one of I think a few problems that I had with the original paper, which I kind of outlined here, is that one is the study. A lot of the studies are small retrospective. They don't have a control arm. That's one of the problems. The radiology, as you know, is extremely important. When was it done? Where was it done? What type was it? Who read it? You know, all of these things are important when you evaluate patients with HCC. In patients who get TACE, Y90, it's sometimes extremely difficult to say if the patient is cured. So I don't know why, you know, that's important to pay attention to. Like when you say somebody's cured, sometimes on imaging is extremely difficult to know that. One of the studies we briefly looked at was on the explant. Patients who had an explant post-transplant, patients who got TACE pre-transplant, we looked at the explant, and I would say 80% of those patients who had TACE had viable tumor still. So that's a good example that you still could have a lot of viable tumor there. Heterogeneity between the studies, that's always a problem. Type of the HCC therapy, resection is different compared to RFA. And again, lack of control groups. One study was done by Tabrizian here, showing that kind of give an idea what's the risk of recurrence after resection. These numbers are important. So, you know, at 5 years, there's 70% risk of recurrence in patients with HCC. So it's extremely high. So we have to keep that in mind. I think the thing this original study is trying to say is that they see 40% risk of recurrence at 4 months. And that's true. We don't see this in the studies that was published by Tabrizian and others. I think this number is higher than what Tabrizian has been reported, for example, at 35% at 1 year. So I think that's one of the points they're trying to make. But again, I think there is a lot of downsides to the study. The same thing with RFA, kind of similar numbers. I think that 40% that the study is reporting is higher than what's been suggested in some of the studies by RFA. There is a multi-center study that's being done by Amit Singhal right now. So we'll see the results. It was published as a poster in ASLD. You know, they did not show any increase in recurrence of HCC post-DAA, but they think maybe it's not so much about the number of recurrences, maybe it's the shorter time to recurrence. So that's something we should keep in mind, and we'll see what this study will show when it's finalized.
4 participants in this study, and Suresh Misra is the main guy collecting data. So
I did not know that.
90 cases. 90
Great.
cases.
I actually like this study. Is it being done in the prospective fashion?
No, mostly retrospect. No, it's a retrospective.
Retrospective, okay.
And yeah, we should have an ASLD abstract.
Okay, interesting. Again, the proposed mechanism has been suggested is because we're shutting off the viral replication with sudden decrease in the viral load. You know, the AST/LT going normal. There is a change in the immune system. Maybe there's a problem, like a change with the immune surveillance when you're shutting off the immune system related to Hep C, and maybe that's why we're having HCC recurrences.
Just a dramatic decrease in expression of
very fast and very fast, right?
The interferon-stimulated gene expression decreases dramatically when you treat with DAAs. And since interferon is an anti-tumor agent?
Yes, anti-proliferative, yeah. So, and again, I think this being shut off so fast because a few days or 2 weeks, like we see the virus is already gone. Just a few points I wanted to make. I don't know if this has anything to do with it, but there were a few papers like recently published and talking about patients who are having occult Hep B or Hep C infection within the tumor. So it means like when they tested the blood, there was no evidence of Hep C, Hep B. When they tested the tumor, there is RNA of the virus or DNA of the hepatitis B virus inside the tumor. I don't know what to make out of it, but again, there was a kind of a similar paper that was published recently in Gastro and talked about a similar concept. These were patients post-transplant that received DAA, then they were cured. And then when they looked at some of the patients who had ongoing AST/LT elevation and they did liver biopsy, they detected HCV RNA in the liver tissue. And I don't know, Andrea, what to make out of this, but there were a few papers out there that kind of, I don't know if this has to do anything with these tumor recurrences, but there are some papers out there. The last part of my talk is about looking at DAA response rate in each category of patients, briefly going to patients who undergo resection or transplant or chemotherapy. With the resection, we don't have a lot of data. I think we probably need more data on this topic, but the papers that I showed you earlier showed that the patients who were resected had higher SVR rates compared to the patients who were not resected. And you can see the number in here, 42% versus 3% failure rate. And again, when you read through these papers, it looks like the reason for that is more about having active tumor versus non-active tumor, and kind of goes with the mechanism that was proposed. Again, there was another study that looked at this, and SVR rates in patients who had resection was 79%, was highest even compared to the people who received sorafenib or TACE or RFA. Again, I think is more talking about maybe more active tumor versus non-active tumors. What about the topic of liver transplant, the response rate in transplant? There was one paper that looked at this, and basically what they showed is, let's look at the all patients here, and we are looking at the SVR. Patients who have active tumor, they have less SVR rates. But when you do the transplant, post-transplant SVR rates goes back up. So, it looks like post-transplant is not a problem. I mean, the patients who have HCC when they get transplanted, because we don't have any more active tumor, the response rate goes back pretty good. So most of the patients respond to the Hep C medication. One of the things post-transplant I think we should pay attention to, some of the patients are anemic, renal insufficiency, we have to pay attention to the ribavirin regimens, and there's the interaction with immunosuppressions these days is not a major problem. One kind of thing I wanted to touch base about pre versus post-transplant DAA therapy is pretty controversial. The whole point is if a MELD is too low, probably treat previous to liver transplant to avoid liver decompensation. If MELD is too high, try to not treat and get a Hep C positive donor and then treat after the transplant. the ideal MELD score to do this is still not entirely clear. It could vary between centers. A lot of the other factors are involved when you're talking about liver transplant, the MELD scores, MELD exceptions, which you get for the HCC patients, and there's a talk maybe this will change soon. The regions, the wait times are different between regions, the blood groups are different, and then of course the hepatitis C status of the donor will make a difference. One kind of concept paper I wanted to touch base about, this author was here recently at Sinai and gave us a talk, but they looked at, these are non-HCC by the way, but I think I just wanted to talk about the concept. And they wanted to answer this questions of where exactly, what MELD score do we treat patients with hepatitis C? And they looked at kind of like a model, and they looked at patients between MELD of 10 to 40. And they looked at the two scenarios, treating before and after transplant, and they looked at the survival rates and benefits. And what they showed, and they also looked at based on each region, because again, the wait times are completely different between regions. What they showed is that they suggested that when a threshold of MELD score to treat Hep C before transplant should be around 23 to 27, which will be different between the regions. And it will be lower for UNOS regions 3, 10, and 11, and this MELD score cutoff should be higher for places like New York. You know, the wait times are longer.
This modeling was also based on the assumption that the patients who remain hepatitis C positive pre-transplant would have a little bit more of a donor pool because of the hepatitis C positive organs. But now with people who are hepatitis C negative getting hepatitis C positive organs, I'm guessing that curve is going to shift towards the right in all the regions where the score threshold might be.
Yeah, I was actually going to talk about that too. I think that's extremely important. And again, the MELD exception points are changing too, probably for HCC. That will make a huge difference. Again, the problem with this paper is they only modeled genotype 1 mainly. They used the data from SOLAR 1 with Harvoni mainly, and then they used non-HCC patients. They didn't include blood types, and they didn't include the delisting data. Regarding, one might ask a question of, okay, how many hepatitis C positive organs do we have, right? And that was something that was studied in this paper, and this was grouped by Hopkins, and they categorized the patients into interferon-only era, DAA interferon, and these are the DAA patients. As you can see, the originally was about 6%. These were the hepatitis C positive recipients who were hepatitis C positive donors. So it was about 6%, and over time actually has increased in the number, and could be related to maybe the young donors from IV or drug overdose that we kind of see, and that's probably what they're showing in this paper. One of the things I wanted to show that the Hep C positive status, the donor status, is a center-dependent thing. Some of the centers are extremely dependent on these organs. You know, when you work in Baltimore, you kind of realize when I was there, it might be different between different programs and different regions. They also talked about discarded Hep C positive. I think this also is important. And as we have now more DAAs and we understand these organs better, I think they're less and less discarded organs. So a lot of them are being used. So some of the ones that are not being used probably are not good quality organs or have a lot of fibrosis. And then the other thing I wanted to show is that eventually only 8% of the patients receive hepatitis C positive donor. And if you pay attention to this, the MELD scores actually in the people who received Hep C positive donors was less. And one of the problems is they also included patients with HCC, which is a bit different. So I think maybe they should separate those two groups. But the wait time between the two groups were not different between these two groups who received the Hep C positive versus Hep C negative. But to your point, yes, the Hep C positive organs now are being used for Hep C negative organs. But I think, maybe Dr. Esquiano knows, but we don't really know what's the future will like. Are they going to come with policies that you only can use those organs for certain patients or not? I think maybe the policies change in the future. I don't know, but it's a very good point. One of the other papers that I wanted to show is that this study looked at patients who were treated with Hep C treatments, and these were child A, B, C. Just wanted to show that one of the things that you can see in patients who are cirrhotics, if you treat them with Hep C treatments, they might have MELD improvement. And this was shown in this study, and about a third of the patients who were treated, they had improvement of the MELD score and actually were delisted from the transplant list. So that's another factor that I think we should keep in mind. And again, you can see this kind of inactivated patients were more common in patients who had lower MELD scores, and kind of decrease in people who are, so the people who are extremely decompensated, maybe their delisting factor is less relevant.
Can you talk a little bit about how long they followed the patients? I'm really curious. If somebody is inactivated, what is their course going forward?
Well, I guess everybody's different. This group, they actually had another follow-up paper that was published, I think, in Hepatology International. They followed their patient, I think, for 60 months. But again, the problem is the follow-up is very variable if you look. It's not, I think they didn't follow everybody the same amount of time.
Right, I get that. But generally speaking, these people who were inactivated, did it sort of give them a new set point, but they continue to have progressive liver disease, and 4 years later,
so yes, there is. So again, right, everybody's different. There is a terminology called MELD purgatory that has been used, or whatever you used. I don't know. Talking about
purgatory. Does that cause people to be delisted? I thought MELD purgatory.
MELD purgatory refers to a patient when you're basically decreasing the MELD a little bit.
Right.
They're
Are
still
you trying to figure out when they get delisted, like where they go? Do they go back to their general liver doctor?
Now, I'm not interested in where they go for their care. I'm interested in what happens
How
to their
long
health and
follows?
how long? What happens to their health and longevity? In other words, what is the prognosis for these people who get delisted?
Yeah, I think it could be to different types of patients. I don't think everybody. I don't know the exact answer, but I think every patient might be different. Some might decompensate down the line, and some might stay the same in the purgatory state, meaning that.
So no publications on this.
I mean, like the main papers I saw were these two papers. I mean, I'm happy to send it to you.
Yeah, thanks.
It hasn't had the DAAs for that long to observe the natural history for these patients.
Well, 2014, 4 years.
And I'll also make a point that for a headline, delisting patients with success of DAA sounds really great. But if you go back to your previous slide, patients with a MELD of less than 16 would be good candidates to get treatment. They probably wouldn't be listed in many liver transplant centers.
Yeah, you're right.
So for us, delisting means they were never listed in the first place. And I'm not saying that I think.
But some centers list even MELDs of 8, 9. I mean,
right. So in many ways, it's sort of a subjective kind of thing. It sounds good to be on the waiting list, but if the cutoff for the benefit of transplant really is at a MELD of 15.
Right. We're talking about these two groups. You're right. That's a valid point. I mean, it's only.
So the second point, though, is if the benefit seems to be greatest based on that Markov model in our region 9, to treat these patients, greater than MELD of 20, 24, things like that. If the MELD doesn't lie in terms of their natural history, it sounds like the benefit is quite small. Even if
you're talking about that group, yes.
But there is I don't remember if it's in this paper or in a different one, where they actually look at also the proportions that have loss of ascites and encephalopathy complications versus progression of those things, and you see sort of similar, some people get better and so they.
But I think the problem is we can't put any of these patients in a box and say your ascites and your encephalopathy is going to get better, so we're trying to
Yeah, it's just
who we can
it's
target
hard.
and treat.
Yeah. In clinic, you see all sort of, some do great, but some kind of linger for a while and then they get worse or they stay kind of sickish.
Yeah, and then some of them you treat them and they just stay, like you said, getting paras every 2 weeks and
exactly.
no kind of quality of life. Now they're cured and they got to get a Hep C negative liver.
So again, I just wanted to summarize this part. I'm almost done with the part. Again, these papers talking about pre-transplant versus post-transplant. There's if you treat pre-transplant, there are some pros and cons. You may improve the MELD. You may prevent the need for liver transplant, but again, some patients might go to this kind of MELD purgatory kind of state. You might have lower SVR rates, as we discussed. There are some possibilities of kind of, if you fail treatment, you might have more RAVs down the line, which are resistant variants of hepatitis C. If you treat before transplant, you might lose the opportunity of using hepatitis C therapy, and but again, there are some use of hepatitis C positive organs. How is it going to be in the future? Do you treat 2 times? I mean, do you treat before and after? I guess these are like some of the questions that might come up. This DAA and HCC recurrence is still not sure. We probably need better studies. The treatment post-transplant, I think the SVR rates are great. And if we treat, we can use the hepatitis C positive organs. It might improve the wait times on the transplant list. And we don't have any concern about DAA and HCC recurrence in those patients. The cons will be, these are patients, if you wait too long, they might get too sick and unfortunately die on the transplant list. And when you transplant somebody, you might change their genotype and would be more difficult to treat genotype 3 rather than genotype 1. And there are some concerns about this rare condition of fibrosis and cholestatic Hep C that will come up. Last part is briefly, what about the patients who are in the stages C and D? With the hepatitis C and liver cancer, we get this question a lot from the oncology colleagues. They refer to us with active hepatitis C and ask us, okay, what is the effect of immunotherapy on hepatitis C? This was one of the papers that looked at this question and kind of all over the place, but in a lot of the patients, actually, they showed that when you use the anti-PD-1 or CTLA-4, the hepatitis C levels drop. So actually, maybe it has a protective effect. With the hepatitis B, it's still a little bit less clear because most of the patients with hepatitis B were put on hepatitis B medication prior to being enrolled in the clinical trial. So we don't really know about it. But we don't really know this yet, but I mean, currently the patients with hepatitis B, they usually go on treatment or prophylaxis. And with the hepatitis C, we do not hold their chemotherapy or immunotherapy drugs, but we have DAAs available, so when we see them, we request the medication and we treat them with the hepatitis C drugs. So because they're available and they're great. That's it for me. Thank you very much.